All right, so in thinking about maternal systems to think about as the labor and delivery nurse when your patient is in labor, we're going to start with mom's cardiovascular system. So during labor, and just like when she was pregnant, you don't want to put her supine because clearly that's going to reduce blood flow to the placenta. And you already know at the peak of contractions, the blood flow is reduced. So best positions during labor are semi-followers or side lying. Really the best position is upright. But once your patient has an epidural, she can be side lying, one or the other. But really the best position is to be up and ambulating if possible, or sitting on a ball at the side of the bed. A birthing ball is what I mean by ball. So respiratory, right? She can be breathing really rapidly. So you want to think about that. She's working, she's in pain. I reference labor as the biggest workout of your life. So think about what that means in the context of her giving birth. So I have a star next to the GI system. So your book and most hospitals really recommend that the patient has low or no intake. So please don't bring your patient in labor and delivery anything to eat without clearing it with the nurse that you're working with first. So taking that textbook piece aside and putting on my midwife hat, in a birth center, in low risk settings, we're okay with women eating. The literature on this supports that it is okay to have women eat if they are hungry during labor. I can promise you, once somebody is in active labor, the last thing they want to do is be eating. But in early labor, if that takes women a couple of days, they're going to be hungry. And you want to think about it. You're doing the biggest workout of your life. You wouldn't starve yourself during a marathon. But again, please don't bring your patient anything other than ice chips unless you clear it with the nurses first. The reason that in the hospital this policy exists, I just don't want you to think it's this hospital versus midwife thing. What it really is, guys, it comes down to anesthesia sets this rule because if somebody has a crash section and needs crash C-section and needs general anesthesia, you have to think about it from the perspective of intubation, right? They're going to not want to do general on somebody who just ate a meal. So that's why we always want to check first. Okay, in labor, the woman is not going to feel that her bladder is full. She's got a lot more pressing pains going on vaginally and in her uterus than to think about her bladder. Now, I want you to think of the bladder as a water balloon filling up and the baby, the fetal head, above it. If that water balloon, that bladder, is getting bigger, it's going to act as an obstruction to the baby coming down the birth canal. So it's our job as nurses to ensure that mom is getting up to void every hour, whatever it is for your patient. But you really want to make sure that she's emptying her bladder and she won't feel that urge. Thinking about her blood, you want to think about the fact that she's going to lose blood after she delivers this baby. So knowing what her hemoglobin and hematocrit are before she's given birth and then comparing that to her postpartum one. And remembering and having a strong appreciation for the hypercoagulability of a pregnant woman. And that hypercoagulability will stay with her for the first 6 weeks postpartum. So, in terms of fetal and maternal blood, you know that they don't mix, but you know that in the uterus, there's this exchange in the intervillous spaces that occurs through diffusion. So I'm going to not do this link. I apologize. I have another one. For whatever reason, this one's only lasting for a short amount of time. So let me pull you out to the other link.
Of the baby, and the umbilical cord is the lifeline between the mother and the baby. Labor is the process of the uterus contracting to dilate the cervix and to push the baby out. With each contraction, blood flow to the baby is reduced, and removal of waste is reduced, reducing oxygen transfer to the baby, and removal of waste from the baby. The baby will do best with 2 minutes of relaxation between contractions. However, as the time between contractions shortens, the baby's reserves will decrease.
All right, so that was a good visual about maternal and fetal blood flow during contractions. And this link at the bottom, if anyone wants to follow it, will take you to a really fun video. It's called a fetal circulation wrap, and it will review with you what is occurring for the fetal circulatory system. It's actually a pretty fun 2 minutes to watch. So the video, I think, just really spoke to the placental circulation, so I'm not going to go through this other than to say we started to talk about patients that have pre-existing medical conditions, so maternal patients with pre-existing conditions such as diabetes or hypertension. They're going to have decreased blood flow in general to their placentas, so now you couple it with the decreased blood flow that occurs at the peak of contractions, and that baby is more likely to have a more difficult time with labor. The fetal cardiovascular system, like I said, that fetal wrap is a really fun way to review it. So I encourage you to follow that link and you'll have a good laugh if you do. And to remember what normal fetal heart rate is, so 110 to 160. And realize if your patient and fetus are premature, that heart rate is going to be on the higher end, and that's considered normal. Okay? When a fetus is not tolerating labor, how they're going to show that is through their heart rate. So the variability will not be moderate, which is what is a good thing. It will start to drop to minimal. And the baby's heart rate may go high and then followed with bradycardia. That's how the baby's going to tell us it's not tolerating labor. And how do we know that it's not tolerating it? We usually will have the fetal monitor on. So this is showing you a cross section, if you were to sort of cut into her uterus, that you're putting this fetal ultrasound monitor over the baby's back. So this I just want you to remember, it's going over the back is the best spot we're going to hear the baby's heart. And then up at the fundus is where we're going to put the monitor for contractions. And I want you guys to remind me in class to discuss the advent of fetal monitors and sort of what it has caused. So I'm going to give you a brief intro to that by saying that since fetal monitors, electronic fetal monitors, have come into play, the C-section rate in the US has simply increased. And we see more women with epidurals and more women who are told they need to stay in bed because we need to monitor their baby. We know that physiologically the best spot for a mom to be laboring is up and moving. This fetal monitor is not necessary for a low-risk woman who has no complication and whose physician or midwife says, you know what, we can just listen intermittently, and there's protocols for when a woman is in labor to just listen and document the fetal heart rate at the hour mark, and then as she gets further every 15 minutes, and then with every contraction as she's pushing. So there are variations to this theme, but I want you to have an appreciation for just because in the clinical setting you see everyone on a fetal monitor doesn't mean that's the right way that we should be doing things. Okay, and we'll talk about that more in class. There are, once a woman's water has been broken, two internal ways to monitor the same two things we were monitoring externally, so fetal heart and contractions. A woman's bag of water has to be ruptured, has to be broken in order to use these two things. They're really used to assess, one, if we need to internally monitor the fetal heart rate, it's with a fetal scalp electrode. This just gives us a better picture of the variability, so that beat to beat. So if we have a baby who looks like it's not tolerating labor very well, the variability will be picked up on better with this FSE. The internal pressure catheter, the IUPC, intrauterine pressure catheter, is literally a catheter that goes up along next to the baby and measures the strength of the contractions. So this should sound sort of on alert to you, great? We weren't able to measure strength before, so we use this internally if a woman is not progressing, not changing her cervix, and we need to be monitoring the strength. That's all I'm going to say about these two things, because when we talk about how to read fetal heart rate monitor strips, I will talk at length about both of these devices. Just some of you will be on labor and delivery and see them, so I want you to be familiar with the terms before we have that class material. So fetal lungs, to think about here, the benefit, there's many, but the fetal benefit, one of them, of having a vaginal birth is that the baby's lungs are full of fluid when it's in utero. Think about that. baby is practicing swallowing and breathing amniotic fluid. So it would make sense that there's fluid in its lungs inherently from that process. So think of birth now. Think of the squeezing that occurs. That process is physiological for that fetus to expel that fluid that it's in its lungs. A baby who's born by C-section is going to be more mucousy, more sort of junky. You're going to have a lot more secretions coming from that baby's mouth. And we want to be cautious and considerate about that when we have newborns we're caring for that were born by C-section. We don't routinely suction babies, right? It's just going to be irritating. If that C-section baby is very mucousy and it's affecting its breathing, then yes, we will. But in general, healthy births, we don't suction. So the stages of labor, this is a really important slide and I have it in here twice. The first stage of labor is actually the first stage is 3 phases, okay? So when a woman is in the first stage of labor, she's between 0 and 10 centimeters of cervical dilation, okay? This first stage starts once she has regular contractions that are changing her cervix, and it's going to end when she's completely dilated. So in this first stage, in the first stage, the latent phase, she's going from 0 centimeters through 3 centimeters. This latent phase of the first stage can take days. I said that correctly, guys. It can take days. That's not abnormal, especially in a new mom. I'll see somebody, it can even take weeks. I'll see somebody at 37 weeks and checks their cervix and they're 1 centimeter and they could still be pregnant 3 weeks later. Okay, that's not a problem. Active labor is when somebody is between 4 and 7 centimeters dilated. Most of the time, this is when we want to be admitting patients. They have a nice contraction pattern, their cervix is changing, they're usually contracting every 3 minutes at this point. Labor is starting to get intense here, okay? Transition is when a woman is between 8 and 10 centimeters or fully dilated. Transition is the most intense portion of labor, but it is also going to be the quickest, thankfully. Usually this transition will be just somewhere between 2 to 4 hours if all is going well. So the first stage has these 3 phases that you just need to know and understand and be able to articulate where your patient is. And note, this has nothing to do with whether or not she's ruptured. It simply has to do with how many centimeters dilated she is. She can get to fully dilated and not have broken her bag of water. That's totally fine. Okay, the second stage of labor, guys, is from the time she's fully dilated till the time that the fetus is delivered. Third stage is, just think placenta. 3 is the placenta. This is from the baby being born until the placenta is delivered. And then the fourth stage, you're probably saying, why is this even a stage? Because mom is going through so many shifts in every dynamic of her body at this point. So she's doing maternal hemostatic stabilization. This is the fourth stage from the time the placenta comes out for the first about 4 hours postpartum. And just a note, the third stage for the placenta should not take any more than 30 to 40 minutes. We should only have 30 to 40 minute gap between baby and placenta. All right, so I want you to look at these positions, think about the comfort measures we can provide for women, and we will pick up talking about that. This picture may help you as well in thinking about what sort of comfort measures are being done for her. And I really want you to feel comfortable with those stages of labor so we can articulate and chat about them. All right. And I will entertain any questions, obviously, on this material by email or by